All right, good afternoon. So this session is Insights from T1D Exchange. I'm Abha Choudhary. I'm a pediatric endocrinologist from Children's Medical Center, UT Southwestern, Dallas. We are one of the newer centers to join this collaborative and really excited to be here. Want to introduce Anne Mungmode, who's going to talk to us about T1DX QI portal updates.
Okay, great. Thanks so much. Let's see, get a hang of this. Great. So those who don't know me, I'm Anne Mungmode with the T1D Exchange. So you may see me as a QI coach with some of the centers, but one part of my role that I really enjoy is monitoring and managing our QI portal. So this is our online EMR database where you can log in, anybody in this room, if you haven't already, you can create an account and there are several things you can do on the portal. So I'll share a little bit of that, but I'm mostly really excited to share some ideas of what we want to do for 2024. We want to continue to make it a tool that is useful to you. It matches some of your expectations or other things that you're looking forward to and continues to support your work, not just as a QI tool, but as a really robust data tool. So everybody in this room, you're part of my focus group for that feedback. I'll share a quick video and then there'll be a QR code. Anybody who completes that survey does get entered into the raffle for a $25 Starbucks gift card. So none of the other breakout sessions have perks like that. You picked a good group for that. And I did just want to clarify, so we have two main websites that we encourage you all to have an account with and to use. So the QI portal is the data platform that I'll spend most of today talking about. You can see some of the things there. You can upload your QI projects if you haven't started doing that already. You can benchmark EMR data compared to other centers. You can also access our WRIT library, which has nearly 200 resources in it. There's examples of other QI projects that people have completed in the past. So if you're thinking about what's next for my team, or I really want to get some inspiration, that's a great place to go. And I want to differentiate that from our member website. So this is our other main page. You may, for some of you who are with us in 2021, 2022, you know, we had Life QI, we had Trello, we had the portal, we had this. So we're trying to make it just these two main platforms is all you'll need to access anything for T1D Exchange. This member website on the right-hand side, so that's where you'll find the meeting minutes or any information about committees or special projects. If you have a question that you'd like to ask the entire collaborative, that's a great place to post it so anybody can log in. There's been some great questions in there about, you know, how do you document different things in your EMR, or what do you do in this challenge with a situation or patient or a process flow? So could the sky's the limit to the kinds of questions there, and those go straight out to the community. So you don't have to go through us, just ask each other. So those are two different platforms. If you think you're in one, not the other, please, we can help make sure you're in the right place. But for the QI portal, coming back to that database platform that I'll spend time talking about today, we had a lot of really exciting updates in 2023, and thanks to many of you have been involved in different ways of informing us of what those things should be. So when we first started the portal, there was maybe 5 metrics in it, and you could benchmark for 1 year and look just at 2021 or just at 2022. So we've been able to really expand and very excited to be able to do that. Some new metrics that are available this year. So more and more of you are reporting some AGP measures, time in range, time below range. So we're starting to have some really nice data that you can compare and benchmark for that. We also expanded social determinants of health. So if you haven't logged into the QI portal in a little while, previously we only had food and security, but now we have information on these other social determinants of health, and we want to be able to differentiate those so you can connect. We also have severe hypo is a new measure, and hybrid closed loop. We know that's something that we'll be talking a lot about at the conference. And for any of you who are trying to figure out how do you map to hybrid closed loop, we're getting a lot of those questions. So feel free to keep those coming. We have all of those answers ready about how to support some of that mapping as well. The library I already mentioned when I made the slide last week, over 175, we're up to 185 resources. It keeps growing. So there's a lot of stuff in there, and many of that is informed by the work that you all do. So thank you. That's a really nice collection that demonstrates everything that you all are contributing to. And then we have new data tables under report charts. So that was a feedback from one of you, actually. Somebody said, you know, it'd be really helpful if we could see the data under those report charts, not just the trends and the nice outcomes. We want to know how many patients are included in this month, and of them, how many of CGM or whatever that metric is. So thank you. That was, if we are open to and grab onto those feedback. If you have something in the portal like that, that can be really quick for us to incorporate, and we really like hearing those. I will spend a bit of time sharing about the improved tabs. This is the 5th tab in the QI portal. If you haven't logged in the past few months, it might be brand new, so I'll spend some time sharing that. This was an inspiration to remove us from LifeQI, if anybody remembers that platform. It was a little clunky. It was another system we had to log into. We wanted you all to be able to do that in the portal in the same place where your data is, and to make that just as easy and feasible as possible. So you can document your QI projects. If you haven't done that already, please connect with your QI coaches in a QI call. Starting next year, what we'd love to do is for you all to be able to present your projects through the platform on the coaching calls or on other special project calls. So this can all be in the same place. If you use a PDSA template already and you really like it, you don't have to retype everything. You can just upload your nice template, and that can count as documenting your PDSA cycle, or you can document and type those things in individually. The platform also allows you to tag other members of your team. So it's really clear, I know that Dr. Mary Pat's on my team, or I know that Barbara's on my team, and you can connect with them. You can assign PDSAs to them. So it's really clear, assign those time frames. A nice way we want this to be a tool to help you monitor your QI projects. We heard that would be helpful. That some of you are using like rolling checklists or Rails or other things. This could be a way to be able to track your progress. And then we just released, we're really excited, on the improved tab, you have your improvement metric, and you can annotate those metric charts. So you can add a little note like PDSA occurred here, or maybe a staff was out here. We weren't expecting that. If it was something else, other observations that we have about our QI projects and things that are going, you're welcome to document that, and anybody can add to the project. So that was another thing we wanted to do different from LifeQI, was we had one person from each clinic could have a profile, but we wanted to open up that gate. Anybody on the project can add a PDSA, can add other members, can annotate the charts. So please, if you haven't already, check that out and ask your QI coach about that. This is what I updated last week, so there may very well be more centers. If you're not up here, I missed you in the last week if you updated recently, but we're seeing more and more people are uploading a project. So if you're not on this list, that will be our homework between now and the end of the year to get a project in. And if you have PDSA cycles or QI tools uploaded, we'd love to see that as well. Not just to have you use this platform, again, as a standard way of communicating with us about your QI projects, but that would be really nice in the future, once we have enough projects in here, that we can open them up so you can see each other's projects and learn directly from, oh, is somebody else doing a PDSA around a paper screener? Let me see how that's going. Or somebody else doing a PDSA around this. So the more projects we have in there, the more meat that we have to justify resources to build that and have that be a part of the improved tab. So thanks everyone for who's already doing that, and looking forward to seeing more and more uploaded there. So for 2024, we have 4 new designs. These were all things that we heard from you, we thought would be interesting. We're going to share a design around type 2 data. We know that more and more that's becoming a need. More and more of our centers are interested in that. You're mapping to our type 2 data specification, so we have an idea of what that could look like. The Insights tab you'll see in the video is a little bit more analytic ability outside of those 14 QI measures that you have now. So not just those 14 and the time frames, but you all map over 100 variables to us. So there's a lot of meat that we get in your data that we want you to have more direct access to. So if you wanted to run a quick analysis on number of patients with A1C less than 8, who are also using a CGM, who are also using a pump, things like that, where we can combine and have a little bit more of those, still simple, but more complicated than the QI measures in the portal. We want to explore access to that. And then with the report tab in the library, you'll see in the video, as we've grown the portal, 200 resources in the library, over 30 metrics and filters in the reports tab, we want to make those easier to use. When we originally designed them, we didn't design them for that volume of things, so we will have some ideas for that. And again, there'll be a survey at the end While they're figuring that out, does anybody have any QI portal questions? How you're using it now or things? Yes, Mary Beth.
So I think that we are still entering things into live QI, so we're not supposed to be doing that.
No, you don't have to do that. Yeah, you can enter it right in the portal. If you have documentation you upload to Life QI, we can download it for you and put it, so you don't have to let us know. We can transfer that for you.
Okay.
But we'll grab that for you. Yes. If anybody's still using Life QI, let us know. We'll switch that over for you in the QI portal. Yes.
Considerations for the overall site dashboard projects.
Yes.
Last time we had a site in Excel, so we could put it on it.
Yeah. So there was a question if we can see all the QI projects. That's a feature that we have for the improved tab, so you can see everything that's going on or things that have happened in the past. Was that your question? It's not already in there. So you can see your projects currently, but that's something we'd like to do in the future. Yes, Barbara.
Regarding screening for social determinants of health, we at UCSF Pediatric Diabetes in San Francisco are currently screening for food and transportation, but not housing. So is the way you track it looking at each domain separately, or is it all or none?
It's each domain separately. So as your team is mapping, they can connect those pieces, transportation, food security, to the appropriate spots, and we'll be able to separate those. Yeah.
Okay.
Yeah.
Any other questions?
Yes.
Just a quick logistics, a follow-up. You said that if it's already in Life QI that you'll transfer it. Did that happen already, or do we have to ask for that?
No, we can do that.
Okay, but it wasn't like automatically everybody's was already transferred. Okay.
It wasn't, yeah. So
okay, no, that's fine. And then
now that I know that there's fresh stuff in there, we'll take a look at that. But
mine's not fresh stuff, but there's something in there. Okay, sounds good. And the website is, could you remind me of that too for the portal?
Yes. Oh my gosh. It's like qi.platform.auth. I think I'll have to double check that for you. Because it's a weird web link. Oh, was it? It was on my first. Thank you very much. There it is. qi.t1dplatform.org/home. The E is hanging out in the second line. It is home. The E didn't want to hang out with the rest of the. Okay. Let's try this video again, see if we got.
Thank you for your time to help define the direction of future QI portal development. T1D Exchange is committed to enhancing the QI portal in ways that best support your work, incorporate best practices and robust tools, and align with emerging diabetes care needs. In this short video, we will share 4 design visuals and will ask for your feedback in a brief 5-minute survey. More and more centers are mapping to our T2D data specification and providing monthly patient-level information for people with type 2 diabetes. For applicable centers, we envision a QI portal where you can easily toggle between your type 1 and type 2 portal. Visually, different colors will make it easy to see if you are reviewing dashboard, compare, and report tab outcomes for people with type 1 or type 2 diabetes. The Library and Improve tab would overlap for both populations. Next, we have heard your request for more analytic freedom in the QI portal. In the New Insights tab, we envision basic analytic functions that allow you to answer population health questions and display outcomes with various visual tools. For example, this tab would allow for collaborative wide analysis and visuals by US region. An expanded database feature allows you for more direct access to your data outside of our standard QI metrics in the Compare and Reports tab, support research questions, and empower you with more data access. Unlike existing QI tabs, the Insights feature will allow you to analyze across variables for more complex visualizations, in this case, comparing the % of patients who screen positive for depressive symptoms and general anxiety disorder. The visualization options allow you more freedom to tell your story or get basic research insights into your population. Next, we have added many new metrics and filters to the Reports tab over the years. In this Reports tab refresh, we envision an enhanced tab where metrics are organized into categories for easy access. Additionally, Data tables under charts will be more advanced to show outcomes for health equity filters. And finally, we envision a more advanced and interactive statistical process control feature to clearly display shifts in reported timeframes and include tips to describe these shifts in your processes for presentations or publications. Finally, we believe the library is also due for a makeover. We have close to 200 resources available, and we want to make sure the library is easier for you to browse and get you access to what you are looking for. To this point, at the top of the page will be options for viewing resources that are just for me. For example, resources you've liked or relate to QI portal improvement projects or saved reports. You can also view top-rated resources across the collaborative or browse collections such as QI improvement tools or diabetes EMR documentation. Rather than searching by categories, a more robust search panel will allow you to search for resources by keywords, time frame, center type, center name, or category. Finally, additional links are available for external collections, including existing digital libraries or resource collections. You can also access our QI bibliography with textbook or other hardcover reading recommendations for additional professional development. And finally, you can contribute directly to the QI portal by uploading a PDF or a web link to be a recommended resource for T1D Exchange consideration. Thank you for listening. Please use your smartphone to scan the QR code and access the brief feedback survey. After you finish the survey, be sure to see a T1D Exchange staff person to enter into a raffle for a $25 gift card. Thank you.
Thank you, Anne.
Thank you.
That was very helpful.
Absolutely.
Yeah.
Thank you so much. I'll have a sheet too. If you fill out the survey, you just show me your code that you did that and I'll put you in the raffle. Thank you.
All right, moving on to our next session. Next talk, I would like to invite Jeff Hitchcock and Amy Ohmer, who are going to jointly present real-world insights.
So my name is Amy Ohmer, and I've been with the T1D Exchange in this capacity when it first started. So it's been many years now. I want to say it's almost a decade probably from when we initially thought about this as an idea to where we are today. I think to introduce myself, if you haven't met me yet, I'm really outgoing. I love to meet everybody here. I'm so grateful every time I see everybody here because I know that this is how we're going to make change. And this has directly impacted my daughter's lives. I'm the mom of two who were diagnosed at 3. And then the second one, just a few years later, was diagnosed at 8. They're now 20 and 22 years old. So this is how our success story began. And I think one story to just quickly start off with is to say, how many people have decorated for the holidays yet? Is anybody? And you can admit it, this is a safe space. Okay, so we have a couple. Well, I've already decorated for the holidays. And the reason I do this is because my two girls were both diagnosed in December. And the first one was really traumatic. We were in the hospital. She was, I say near death, it's true. She was at the point where she had been misdiagnosed many times. And I'm the mom who Googled. So just so you know what you're dealing with. And that's how she actually got a diagnosis. So weirdly enough, it worked in my favor. I didn't think that it was anything outrageous. It turned out to be type 1. But because we were in the hospital for so long, coming out of it, it was Christmas time, it was really, really difficult to kind of find my foothold. And then I figured it out. And 3 years later, the same thing happened again. But this time I had a daughter who was diagnosed and didn't even need to go to the hospital. So I attribute a lot of that to what you all are doing here and the learning that's being acquired and shared, because that's what happened in my N of 2 household. And that's why I decorate now. So do you want to introduce yourself?
Yeah, we don't decorate yet. My name is Jeff Hitchcock. I run an organization called Children with Diabetes. We are a nonprofit that helps families living with type 1 diabetes like mine. My oldest daughter, Marissa, who is here and was sitting over there talking a bunch earlier, was diagnosed in September of 1989 when she was 24 months old. And as I kind of mentioned, our mission is to provide education and support to families living with type 1 to help people thrive every day.
So when we started talking about what we wanted today to look like, we talked about just kind of opening up our lives and sharing a little bit about ourselves. So I've already told you a story. Jeff told you a story. but we have more. So of course we do, because that's what we do. One of the stories that I wanted to share was another learning that we had. And I think this is a really good way to explain why communication is so critical between patients and their support team. So we're all together, we're all united in this. That's why we wanted you to come and sit closer. And this is no judgment. So these are just things that happen. And I think we learn from them. And then it brings us to a better understanding of what we can be like as we continue on this path of type 1 diabetes. So one of my stories is, as my two girls were growing up, we would go to clinic appointments. And in my house, we would make this a really big deal. So we would pack what I called a bag of fun. And we would prep for pretty much a half-day experience on any given event, where we would come in with snacks and toys that they had not seen, quiet activities that we could have. And honestly, my kids kind of look forward to it for as much as they possibly could, because they knew the bag of fun was coming out. This was kind of a cool event. We would usually tie it into some kind of meal on the way home afterward. And we really tried to make it part of a normal childhood. So it was important that that feeling kind of stayed within the whole clinic room, and that everybody who entered that room had that same understanding that this was a special moment. It might have been the 20th patient somebody had seen that day, but to us, you were the first time that we had seen a doctor. So coming into our room, we had our MA who, we never really know the MAs. I always feel a little bad about that because they do change position quite a bit, but the MA was really nice and friendly. And, I have two kids, so both fingers had to come out. They both have to be poked. There's a lot of, trying to make sure the records don't get mixed up, because we do this all together. And so there's stickers going on this and stickers going on that, identifying whose data is whose. And then we sat back down and we waited, and they were playing with the bag of fun and everything is going well. And all of a sudden, a knock at the door, and our CDE came in. And we knew the CDE pretty well. We had formed somewhat of a friendship. But that day was not like other days. She came in and she was really upset. And I'm kind of one of those people that feel it. If I see somebody's upset, I know. And, I don't know if it's my mom's intuition or if it's maybe being somebody who cares for other people. I'm not sure, but I knew something was off. And she was very abrupt, very short, very kind of angry. And so the room changed. The girls sat up. They put away their toys, looked at me with big eyes. And I thought, I don't know what's going on. We just got here. What could we have possibly done? Thinking immediately it's something that we caused. So after this went on, she left the room, came back with the pump she had taken and said, okay, you're done. And then we thought, oh no, what have we done? So I've never done this before because I'm not confrontational, but I said, I'm sorry, you can't be in here today. And that started a whole hubbubaloo. She left the room. I didn't know what happened in the hallway. I did not need to know, but I knew what was happening in the room wasn't good. So our endo came in, also another very nice friend of ours. And she said, Amy, what is going on? This has never happened before. What happened to CDE? And I said, I don't know, but she can't be in here. So she said, okay, I'm going to go back out in the hallway and I'm going to find out. Well, it turned out that the nurses area was short-staffed that day, and they were asked to work through lunch, through breaks. There were no time to have a snack, to have coffee, to have bathroom break, nothing. So when she came into our room, she was angry and she did not want to be there. And she was feeling really upset about what was happening. But what happened to us is that we received that and we couldn't have that in our room. So as I found out, we had somebody else come in, the appointment went on, the world goes on. It's not the end of the day. We were able to recover. It was fine. As we left, she was brave enough to approach me in the hallway and she was crying. And she said, I am so sorry. I've never had that happen. I don't even want to explain, exactly why this occurred, but this is how I was feeling and I shouldn't have brought it into the room. And I realized at that moment that all could have been solved. All she had to do was come in and say, honestly, hey, I need a break. I need a moment. I would have been fine with that. So what I encourage everyone to do is to use that honesty, that transparency, and tell your patients if you need a moment. It's okay. We will understand. We really will. There are times I need a moment where I can't go in. I mean, I'm a parent, right? So if I'm really angry at my kids, I know I need to take a step back for a second. Or, you know, if life is happening, sometimes I have to get my thoughts in order. That's okay. That's good care. That's equally as good of care as dispensing medicine or medical advice, is to just adapt to the situation you're in, be honest and be truthful. So I wanted to impart that today because I think that's really the spirit of what we're all doing.
Indeed. So I have 3 little vignettes, not quite that long. One speaks to, I guess, provider bias. As some of you know, we hold a conference called Friends for Life Orlando every summer in July. And about 12 years ago, a family came from, I think, South Carolina, and they were seeing the most prominent pediatric endocrinologist in that state, someone who was very revered. And they came to the conference, and the mom walked up to me and said, "My doctor told me not to come. I would come home wanting a pump." And of course, she came home and she wanted a pump. And my experience with that was, you are seeing a healthcare team that doesn't think anything about you. They think they know everything, and you will do what they tell them to do. Now, today, pump therapy in pediatrics is pretty well the standard, but there will be new innovations that healthcare professionals will be reluctant to learn or uncomfortable, and they will think, that's not for you. It's not for you to say that. It's for the family to decide what works best for them. Another really amusing vignette, a gentleman named Kendall Simmons, who was a football player for the Pittsburgh Steelers, an offensive lineman, this big, massive guy, was giving our closing keynote. And he had done a phenomenal presentation. We had about 10 minutes for Q&A at the end. And he's on stage. He's being supported by Novo Nordisk at the time. And right in the front is this woman who was his Novo Nordisk handler. And a kid asked from the crowd, during a football game, if you have high blood sugars, what do you do? And he said, well, I go to the sidelines, I take out my Novo pen, I stick it through my uniform, and I give myself insulin. And that woman jumped up as quick as she could possibly say, grabbed a microphone and says, giving insulin through clothing is off-label. To which I said, life is lived off-label. So take that back to the families you care for and think about, how would you give them the guidance to live off-label? Because that's kind of what we all do. And then the last note, I heard this 2 weeks ago at the ISPAD conference in Rotterdam, where we did a presentation on the importance of screening to detect people before they have overt type 1 diabetes. And there were comments that this new therapy, this Tzield, right now only gives 2 years of prevention at best. And this particular group of healthcare professionals said they would never allow their patients to do that, that it wasn't worth it. My daughter was this big when she was diagnosed. A 2-year delay would have doubled her life without type 1. So don't tell me 2 years doesn't matter. So take that back as you think about screening, because 2 years is what we know today. For some, it might be never getting. So
Jeff talked to me about that story before we came out here, and I said the same thing. I said, you know, my daughter should have been diagnosed when she was still 2. She had her birthday and then was diagnosed. I would have taken that in a heartbeat. And who's to say the science that we know today doesn't change and evolve as we gather more information? So 2 years of data is what we anticipate that drug working. It may work longer. We don't know. So appropriate medicine in this is also knowing your patient, seeing what's maybe out there, you know, being proactive, trying things that are new, finding things that work for them, because I think all of that has been part of our success story too. So the other piece to this really wonderful session, and thank you again for being here, is to open this up to have you ask us questions. And I want to say this fairly, and I really do mean this, there is no judgment. So you have patients you're thinking about, I know you all are, they're kind of across your face right now. I could see like the looks of, I wonder if she knows about this. Well, ask us what you're thinking, because we might be able to open up some insight and share a little bit of our experience and our expertise in being here. Yes.
Okay, so I love the off-label. I also have type 1, and sometimes I say things to my patients and I'll say, I know I'm your provider, maybe I shouldn't say it like this, but XYZ. And the importance of making sure we're doing what the patient wants. Now that pumps are getting so good, and we've worked so hard in our clinic to open it up, stop having these A1C caps, and we're doing it. But now we're hitting this point, and it's starting to feel weird because I still have patients that are reluctant to get on a pump. And now the pumps are more than just a lifestyle choice. We know it helps A1Cs. What is your advice for helping to convince patients to get on a pump without taking away their patient autonomy? It seems like a fine line.
So my daughter went on her first pump at age 11. This was a long, long time ago. She was tired of us waking her up at 7:30 in the morning on Saturday because it wasn't school, but that's when she got her R and the N shots, back then. And I made a deal with her. I said, try a pump for a month. If you don't like it, we'll send it back. No harm, no foul. And all of the companies have sort of deals like that, where if it doesn't work, you can send them back. And letting families know that that is an option, I think could help get people to the point of say, all right, I'll try it. A family that might be struggling economically might think, I can't afford to buy this and have it on the shelf. But if there's a way to be able to say, look, you try it for a couple of weeks. If you don't like it, you can send it back, get your money back. That may alleviate those anxieties. And bribery also works very effectively in children.
I can also add a little bit to that. So I was a mom who was very pro pumping. So when I had my little 3-year-old, I just, you knew I Googled, right? So of course I Googled that. What's next? What should we be looking for? And Animus was the company, the chosen one. And the 2020 was the one that was on the market. So we got that. And my husband was the apprehensive one. He did not want to do this. He wasn't barely feeling comfortable with injections, but we had to do them. So that was what passed the muster for him. So what I did was I took on the role of that. So in some cases, there are other people within the family that are willing to be the person that says, hey, I'm here to help. I will support this. You can go to that person. The other thing that's really great, as I've gone on this journey and as my girls have, they are ambassadors for pumps. I mean, they don't get a commission, but they are happy to show at any point, anytime, anywhere. And they've actually been called by the endo's office to say, hey, if you're here on this day, we have this patient coming in. So they might be in an exam room and been asked, it's no coercion or anything, but they've been asked if they would like to go walk over to the patient who's in the adjoining room, show off their pump, say what they like about it, the sports that they can do. I found that there tends to be just a couple things that are fears, and one is tubing. I don't know why, but there's a lot of people who are worried about something attached to them, and especially the tube, that it's visible. Showing a child who's actually using it with tubing seems to alleviate that, because they're like, yeah, it doesn't bother me. I sleep with it. I shower with it. I do everything with it. It does not bother me. And I think that's really helpful to see that in the wild with a real life child versus an adult.
Yeah. One final note. This is again a long time ago. In 2006, we took a big group of CWD kids over to Italy and met with a peds endo named Andrea Scaramuzza. I don't know if any of you know Andrea, but he lives in the Milan area. And we had a soccer match together, and he gave us the 3 best players, or we would have been destroyed. And we went on penalty kicks. But every kid with type 1 in our group who went there was on a pump. None of his kids were. And in the discussions, we would hear the Italian boys say, my pants are too tight. I won't look nice. And the girls would say the same thing. In 2007, Andrea brought a group of his kids to the US to our Friends for Life conference. Every single one was on a pump. And what he told me is Their kids watched our kids live more spontaneously. The insulin was always with them. They weren't as worried about food and everything. And our kids helped his kids see it was okay. So that positive peer pressure that Amy described can be very powerful.
So we have a great diabetes camp, and we have some of these kids going to the camp, and when they see other kids, like seeing them in the wild, they come back and they want to be on a pump and a sensor. So yeah. Any other questions?
Actually, jumping off of that point, what do you recommend for families? And I know everyone's different, but when the child says they don't want to go to a camp. So, I feel like, I don't know, I'm conflicted about the age at which you feel like you make the decision for them, for the family camp, or, as parents, or what do you advise people?
I'll say, bring them to Friends for Life Orlando. It's Disney World for a week with the whole family. My daughter went to camp first when she was 4.5, a 1-week camp, Camp Glendon, run by the ADA. It was transformational for us as a family. She received an award for summoning the courage to give herself her first shot at 4.5. I went the next year. I hung out in the boys' cabin and I watched. I remember vividly a 16-year-old boy up on a top bunk, and his mother was berating him for about 15, 20 minutes. And I kind of vowed I'm never going to be that parent. So it was very influential for me. But camp is absolutely not for everybody. It's off in the woods. Some kids are computer kids or they're swimming kids. They don't want to be off there. But there are other things. And as I said, our Friends for Life Orlando conference is 2,000 people. You're in a hotel room. Someone else makes your bed. The food's all carb counted, and you're in AC. So, and the whole family comes. That's another option.
So I also had camp kids. So we started at 5 with a day camp. It's Camp Medaicha. It's up in Michigan, accepts everybody, and there's scholarship for almost every child that attends. So it's a lovely, lovely program. So if that is a barrier, which sometimes it is, how do I afford this? There are camps across the US that offer scholarship, and Medaicha happens to be one. The other thing is, in lieu of camp, we also did a lot of fun programs. So there, as Jeff said, some kids just aren't camp kids, and that's okay. We did some QI projects that felt like camp. And for computer programming, we actually did a project with Dr. Joyce Lee when the kids were about teenage years, where they were creating imaginary products with their blood sugar data that would light up and show range numbers. So you could kind of see a rainbow pattern of when you were high, when you were low, when you were just right. And they loved it. So it was a little programming session, but it felt very camp-like because here they are in a room with all these other young people doing the same thing, working on blood sugar stuff. So if you have patience and you have any funding, anything at all, and you have some creativity, you can do some of these projects. So it's very cool.
Yeah.
This was the clock was in existence. So this was more of understanding diabetes and data, and Joyce's very nice pet project that she has. And I loved it as a mom because, again, it was another way to expose my kids to other kids that lived with diabetes. And Joyce is really good at, we talk about diversity a lot. You all have this availability in your clinic to bring all kinds of kids together from all different walks of life. And so that was another really great approach, is that it really did bring kids from everywhere because, again, it's free. And that is always a hardship for families when they're dealing with medical needs, but they could come together and do this really neat thing and be supported. So.
Yeah, speaking of scholarships, at our Orlando conference last year, we fully funded 40 families. So there are scholarships for everything. And for those of you who do adults, we do young adult scholarships that includes airfare. So these young adults, 18 to say 26, we cover every single cost imaginable to get them to the event.
This is like the best conversation ever. So don't be shy. Oh yeah. Grab the other microphone.
I run the family advisory board for our hospital. And we actually have a really hard time getting our families involved in our QA projects. It's probably how we present them, because they're like, well, we're not really interested in metrics. They want to know how like it impacts their care. And I want suggestions on, if you have any, on how to get them more involved and how we can make it meaningful.
So this is where bribery is really great. So gift cards, if you have any little gifts, if you have a PFAC in your hospital, a patient family advisory council, oftentimes they have a goodie closet, and that's also very exciting. So if you can give out swag of any kind, something that's maybe there, kids love that. They love feeling like they're being rewarded. And beyond that, I always say this, it's meaningless to them unless they can see that it's actually been used. So make a fuss, take pictures of the kids that are participating, publish it in your newsletter, put it on your website, promote it, because then what happens is the other kids in the clinic and their parents see it, and then they also want to be involved. They want to be a part of that. It's positive. And it shows that proactive movement to doing something better with diabetes.
Yeah, and Starbucks gift cards are not enough. You need Roblox gift cards for the kids.
Thank you, Amy and Jeff. Thank you so much. Thanks. Are we good? I think we move on to the next. Please catch Amy and Jeff around so we can ask them more questions. All right, moving on to our last talk, building QI capacity, Don Buckingham.
I have no idea how to work this, but we'll give it our best shot. Let's see. Forward. Green works. Okay, there we go. Thank you so much. Well, we're going to talk a little bit this afternoon about building quality improvement capacity. And so I'm going to take us all the way back to that first word and think about what in the world is quality? And one definition of quality might be the standard we accept for best outcomes. Hospitals talk a lot about readiness and reliability. They have to be ready for whatever life throws at them on a given day, and they have to have reliable processes that they can count on to handle whatever life throws at them on a given day. And I know in clinic work, that's exactly what you deal with as well. And so if there's a standard that we could adopt that would be a best practice or bring about best outcomes, that's what we're talking about when we talk about quality. So we want to give it our best every day for those kids or for those adults. And improvement is where we take those quality standards and we improve them through interventions that we can test, that we can implement, and that we can sustain. And so we're continuously improving. We're always trying to make it better because we learn as we go. And as we learn, like Maya Angelou used to say, is that when we know better, we'll do better. Okay, and so that's certainly the truth. And so quality improvement, most of us have a pretty good idea of what's going on there. We've been on a quality improvement team. Capacity oftentimes is a new word, especially if you're not coming out of like maybe a business environment. In business, we really know what capacity is. It's very different than productivity. Productivity means I met whatever my goal was on a given day. Capacity means I can do it over and over and over and over again. So in business, they really manage capacity. And in healthcare, obviously, we're aware of that, and obviously we want to do it. But usually what you hear from the top down is more productivity, please. We just like you to do more, give more, and that sort of thing. You don't necessarily hear much about what's happening in the background of capacity. Capacity is the strength of our team to operationalize those quality improvements and draw upon that strength, that capacity when we need it. And that usually shows up for us in healthcare in three areas: personnel, resources, and time. And probably when you think about it, that's what you struggle with every day and every week is, do we have enough people in the right place to do the right thing as a resource and the time to get it done? So that's our big struggle. So capacity keeps that in mind, and it makes sure that you have the strength you need in those three areas to then have quality and do improvement. So that's sort of what we're going to talk about a little bit. In the T1D Exchange, we use a quality improvement model from the IHI Institute of Health Improvement. and most of you are familiar with that model. I've represented it here. We won't go through it today, but it's based upon the idea that if we go through plan, do, study, act cycles, we can actually bring about change. So we can plan for it, we can do something, we can study what we did, the results, see if we got what we wanted, or make adjustments and keep going. So that's the model that we use, and it's a pretty standard model, and it's something that we can standardize around. So we use that. So let's think about how we can use those definitions that we've just talked about so that we could create more successful teams and build capacity. How do we build the capacity? Well, I think there are 5 areas here that would help us. And let's look at them one at a time. When we think about a standard of quality and we think about how would we build capacity, I think the aim statement is the strength that we seek, the ability to get pretty specific about what it is we want to do, and to be able to communicate that to each other in such a way as that we're all, aligned and tuned and focused and headed in the same direction. And we'll oftentimes take aim statements for granted, and we'll write an aim statement which reflects our intention, but it isn't actually what we're trying to do. And so that's something you can really spend some time on, is thinking about, is the aim statement actually saying what we want to see when we look back on the other end? And so that can be a standard of quality. An aim statement builds capacity. I think intervention sustainability builds capacity. So that when you think about your intervention, here's what we're going to try out and see about making a change. We plan it. We need to determine the aim and the customer. We need to map the current process. We need to identify the appropriate way to measure it so we can see what we have now and distinguish that from what we want in the future. We want to brainstorm change concepts, possible improvements, prioritize, and then make some predictions so that we have an idea of what our expectation is. So if we can do planning well, we can sustain change. If we can actually do well, in other words, if we can test out one small change at a time and really see, did it make a difference and could we make that better, okay, then that again will give us strength and capacity. The study part of it, measuring and comparing results with our predictions, and also using the TID portal, QI portal, because you can use it for baseline in your studies and get an idea of where that might fall out. And of course, the other library ideas. The QI portal is such a wonderful tool to use in this. So planning, doing, studying, and then taking the action itself, repeating the cycle as often as necessary to get it right, and then to share the lessons that you've learned, and then to have fun. And boy, we almost never stop to have fun because we're just so busy. We put our heads down and plow on. But having fun is an important part of doing this. Not always taking ourselves super seriously, realizing that we all dream, we have aspirations, we have things we want to see happen, and then we can make some of that possible today. And to accept that is good enough and safe enough to test and try, and then build and work on that some more too. And sort of have fun while you do it, and not let it become too heady. I think another thing we can do to build capacity is that we can consult our local subject matter experts. That's an SME, your local subject matter expert, okay? And to consult your collaborative partners. Because when we're trying to build capacity and sustain change, a key driver diagram helps us because it provides that subject matter expert map. And that's what I think of as a key driver. I want to take my aim and I want to take it to a competent group of people that they really know whether their process is capable or not, whether it can be ready and reliable on demand. And with that subject matter expert's assessment, ask ourselves, what are the key drivers? What are the things that stand in the way? What are the real world obstacles that we actually deal with? And then knowing those in turn become the drivers. because what stands in the way is the way. That's what Marcus Aurelius said way back when. Whatever stands in the way is the way. And so that's what our drivers are. They're our obstacles, and that's what we have to work with and go around and go through or whatever it's going to take to do that. And subject matter experts know what stands in the way. And that's why it's so important that we go to the people that are actually doing the work we're trying to improve and call on them. And then, of course, collaboratively, we build capacity through what we're doing right now is coming together. And we're seeing what others are planning. We see what others have done. We see what the studies are telling us. We get ideas for the interventions that we can take back. I love to watch you while you learn. And so I can't believe the number of people that are writing notes, and the stuff they write them down on just amazes me. I mean, napkins, envelopes, it doesn't really matter, but they've got an idea or it's sparked a thought and they're taking that back. And that's such a valuable piece of what we're doing here today. I can listen to Jeff and Amy share their story. And when I do, I'm good for another year. I'm okay. Well, point me in the right direction, wind me up, and turn me loose, because the stories they're talking about are what's really this is all about. And then your stories of what you're doing and the results you're getting, everything from the elation of the successes down to the terrible frustrations and burdens that you bear and stuff. It all comes together in a mix that's changing lives, and it's very exciting. So I think all of that together builds capacity. I think improving our multidisciplinary team builds capacity, because I think this is a shared work. It's done in community, and it takes a community or a collaborative of subject matter experts in all of these areas that you know well. And these, of course, are the roles and the people that make up your teams. And then I think finally that effort impact prioritization builds capacity. And this is a tool I use regularly after I do my key driver diagram with my drivers, my barriers, and then the interventions, the ideas I'm going to test to see if I can bring about change. I take those interventions, put them in a list, and then I take them one at a time and I say, hey, this intervention for our team, is this going to have high effort or low effort from our group at this time? Is it going to have high impact or low impact for our patients and their families at this time? And then with those criteria, I can map it on this little grid. And then I get a collection. If I have 10 interventions, I have them spread all over the map. And of course, what I want to encourage my team to do is to take the one that is the low effort, high impact, because that's the one we're most likely to get done quickly, get it done right the first time through, and really start getting some momentum. And so you use this as a way that you can kind of decide which ones are we going to do first, which ones need to be done in parallel, et cetera, like that. So this is part of your strategic planning that you would do. So when we think of the fact that we're trying to do quality, we're trying to improve quality, and that we're trying to have capacity to sustain that quality, these are the 5 ideas that I've shared with you today. I don't think any of them are new. You're already familiar with them. I'm just trying to reinforce. That's why we pick these and why we practice doing these. In the remaining time that we have left, I don't know how much that is, but you'll let me know. Which of these I got 2 minutes left. Okay, so boy, that's great. I never even knew. Okay. So we got 2 minutes. So which of these areas is a concern to you? If you were trying to build capacity, maybe in one of these areas, what would your concern or question be that maybe we could address? Where are you having trouble? Mary Pat, you don't have trouble anywhere. I
feel that resources can be a challenge, as much as we've been really fortunate to have all of the support from T1D exchange. It still becomes an issue that we're not an endless amount of support.
It really does. In the almost 10 years that I've worked in healthcare with all of these things, I find that this issue of having enough people, having enough resources, having enough time is the chronic thing that wears and burdens and makes the work we do harder. And I'm going to tell you a solution to it, but I was going to see if you had something you wanted to throw in.
I just think that once you've picked the intervention, I think this goes off the resource thing. Once you pick the intervention, that's the high impact, low effort. And then you have to decide, well, what's next? That's a sticking point. And it's because you come up like, okay, what resources can we find or whatever. So I think it's off of that, but framing it that way is interesting.
Yeah, and that's right. In other words, there's only so much you can do with planning. There's only so much you can do with strategery and all that sort of thing. This is what I recommend is in the world of industry and business, they have another quality aspect that they use. I don't see it as much in healthcare. I do see it in some of the national healthcare systems in other countries, but it's called theory of constraint. It's called constraint management. Okay. And it'd be fun sometime for us to put a little course together on how constraint management's done. It's something that the managers have to do. Okay. Because what happens is you always have a constraint. You never don't have a constraint. You always either lack the personnel or you lack the time or you lack the resources, or sometimes you lack all three. And so how do you manage that phenomena in what you do? And there are management practices that you can use. They're a little bit similar in your world to things like triage and some of those sort of things where you're managing when you don't have enough of something, you still have to go to work, right? Okay, but there are formal things that you can do that are relatively simple because most of it's raising awareness that, oop, I'm in a situation where I need to manage a resource constraint. And so here are the 4 steps that I go through to do that. Okay, and this is how long I think that will contain that problem until we get a permanent solution. So there's another area of quality that we could explore. I think I need to end now, and I thank you so much for the opportunity to be with you today. Thank you.